Thank you all very much. Thank you all for being here today. September is a nationally recognized month to really highlight something that probably has not been in the forefront a whole lot, and that is the importance of mental and behavioral health for every human being, and especially those in the healing profession of healthcare. We are really excited to host multiple events with the partnership of University of Tennessee College of Medicine, Chattanooga, Erlanger Health Center, and our Chattanooga Hamilton Medical Society, and especially the LifeBridge program, to really bring awareness. As healthcare professionals, we are integrally involved in the healing and caring of others. And many times that same altruism turns pathologic to our own selves, and we forget to care for ourselves. Throughout this month, we are going to use this opportunity to highlight various ways that we can really break the stigma and try to normalize the culture around mental and behavioral health. What I have up here are various events that you have seen over the few weeks. And I just want to thank Kim Judd and Pam Scott for really painstakingly sharing this information. We apologize if we have bombarded your emails, but we really wanted to make sure that this didn't go unnoticed. So we start today's inaugural event with Dr. Stephen Loyd, which I think is the most fitting speaker for this, which I would be introducing shortly. On the 17th, we will have Dr. Chris Cunningham, who is the professor of psychology at University of Tennessee, who's really going to speak to us about why and how this really works and why is it important and what are some practical ways to bring awareness. And then we will have Dr. Michael Barron with the Tennessee Medical Foundation. And I just wanted to welcome him. He's on a call today, who really is working and advocating at a state level and nationally to make this endeavor possible. In addition to that, we are partnering with our Tennessee Suicide Prevention Network on the 20th, and we'll have an axe throwing event there. I would like you all, especially leaders in this organization, to join Dr. Mandriata and myself in sponsoring teams to really get together, use this time to be together in community, but also highlight an important issue. And then October 3rd, we will have a walk, and this will be again in collaboration with the national organization, and it will be in honor of our own beloved Dr. Walter Capote. The other thing that we're going to be doing this month is really highlighting why this is important. Each of us is aware in some way or form, or may have pledged personally, the Hippocratic Oath. And the Hippocratic Oath is timeless. However, it was written at a time when healthcare was very different than what it is today. Our healthcare today calls for a partnership between our healthcare organizations, the interprofessional healthcare team, and ourselves, to be there for each other, to work to caring for each other as we care for others, because it is only through that that we will be able to care for our patients in the way that we need to do. Our healthcare organizations today call us to be resilient, and that can only happen when we take time for ourselves and our colleagues. So please be thinking about the Hippocratic Oath and the Oath to Self-Care and Well-Being. We hope to be pledging this on September 24th as a community together. So with that, I'm going to stop sharing, and I'm going to invite our guest speaker today, Dr. Stephen Loyd, to really help us inaugurate the session. Before that, I'd like to invite our leaders to say a few words, because this event wouldn't have happened without their support. To start us off, Dr. Haynes will be representing the University of Tennessee College of Medicine.
Thank you, Dr. Panda, and just want to recognize all the work that's been done by your team. I know you couldn't do it alone, and we definitely thank Dr. Loyd Dr. Barron and Dr. Cunningham for being willing to speak. Also, I'd like to read a poem that I just found last night. It's the first poem I've ever seen where you can read it forwards and backwards simultaneously with the dichotomy that we face in medicine. And it was written by Dr. Puchalapalli, who's a resident in radiology in Wisconsin. I have lost my passion, and I do not believe that I made the right decision. As I very well know with all my heart that medicine is not for me. Why would I ever think that? I have exactly what it takes to be a physician. What I need, passion, compassion, devotion, I have no more. There will never be a day when I wake up with zest with the thought of taking care of my patient. Why? Is it worth it, I ask myself? Medical training brought the pressure, the fatigue, the insecurity. This is the question I ask every day. Is this where I want to end up? Is this where I want to end up? This is the question I ask every day. The pressure, the fatigue, the insecurity medical training brought. Why is it worth it, I ask myself. With the thought of taking care of my patient, I wake up with zest. There will never be a day when I have no more passion, compassion, devotion. What I need to be a physician, I have exactly what it takes. Why would I ever think that medicine is not for me? As I very well know with all my heart that I made the right decision, and I do not believe that I have lost my passion. So I read that, and we face a dichotomy in the work that we have to do. We signed up for it, but in the dilemmas where there are difficult problems facing us, I would ask you as you listen over the next few weeks to consider a couple things. And that is, see the people around you, choose to see the people around you, to include your colleagues, your staff, those that clean our facilities. And I'd ask that you choose to engage on helping all of us care for our patients well and care for each other well. And that's all I have, Dr. Panda.
Thank you, Dr. Haynes. Powerful, and thank you for reading a beautiful poem. If you don't mind, please sharing it with us, and we'll put it on our website. I think it'll be valuable. Thank you. Next, I'd like to invite Ms. Rachel Harris, the Chief Nursing Officer for Erlanger Health System. Thank you for being here, and thank you for your support.
Thank you, Dr. Panda. Good morning, everyone. I appreciate everyone joining, and I appreciate everyone pulling together during this most difficult time. Suicide is a horrific issue, which we all know it happens in the world, somewhere to someone. Fortunately for most of us, it's indirectly, but sadly, it is still happening. Over the past 2 years, we've experienced this pandemic that is still going on, and it's been very unsettling for all of us, with a lot of fear and anxiety, and it's taken a lot of emotional energy from all of us, and still remains to. Unfortunately, in the healthcare business, we are not able to stop, and the reality is that many of us spend more time either in person or virtually with our coworkers and our patients, our staff, more than our friends and families. So with that being said, we all play a very, very vital role in our team to try to prevent suicide. I feel that giving them the confidence, providing services to speak openly will help in a way to remove the stigma associated with suicide. So I, like Dr. Haynes asked, that we care for one another, that we continue to support, that we show grace and humanity and care openly, honestly, and just continue to support. I appreciate all of you and all the work that's being done. Thank you, Dr. Panda.
Thank you, Rachel. Dr. Barker, representing the medical staff, he is the Chief Medical Officer for Erlanger Health System and also an integral member of our Wellbeing Task Force. Dr. Barker?
Thank you, Dr. Panda. Good morning to everyone. I sort of struggled with what to say this morning. I don't have a poem, but as I thought about this, I had opportunity a few years ago to visit the World War II Museum on the coast of Normandy. It's a very interesting place. And the design of it is sort of a spiral. And it starts off at the beginning with a lot of light, and it spirals downward underground. And as you go deeper and deeper underground, it gets darker and darker and darker. And if you keep walking, you come out into the light again. And I was sort of reminded about some of the historical things that that happened with sort of appeasement by Lloyd George, and didn't recognize the problem and how things were sinking deeper and deeper. And then the recognition of the problem by Sir Winston Churchill and his efforts to get then President Roosevelt to help support the war effort. So without the recognition of a problem of folks sinking deeper and deeper, you can either ignore it and it gets worse, or we can have someone that recognizes it, and sometimes that person even needs the help of another person to help bring people out of this downward spiral from the darkness and bring them back into the light. And I think that's what Churchill did with Roosevelt at that particular point in time. But the intervention changed everything, and people came out of the darkness back up into the light again. And I think that's a pretty good analogy, I think, of what happens a lot with depression. And if somebody doesn't recognize it, you don't have the skills to recognize it, you can't get help to deal with it, you can just be sunk in that dark place. And I think as healthcare professionals, we need to recognize that, you know, that sometimes we need help in dealing with these problems, our own problems, the problems of people that we know. Sometimes we need help recognizing the problem, but if we can sort of keep people walking and moving and provide the help, they can come out of the darkness back into the light. And I think that we've had several discussions about this with Officers Council, medical staff, and with Dr. Panda. And I think the medical staff leadership here is totally supportive of this effort to suicide prevention, which was really brought home to us when we lost one of our surgery residents this year, which was a very painful and ongoing painful experience for a lot of us. So thanks, Dr. Panda. Thanks to all of our speakers. Thanks to, there's 57 people here this morning that are interested in this. So thank everybody for being here, and thanks for everything you've done, Dr. Panda, to put all this together.
Thank you. And, you know, as Dr. Haynes mentioned, this doesn't happen with one person. There are many on this call today and many behind the scenes who work and bring their ideas together, have the courage to speak up. So thank you all. Special thanks to the members of the Wellbeing Task Force and of the Resident Advisory Board. Wouldn't be able to be here today. Your support and championing for this cause has been just, I think, more catalyzing. And then last, before I introduce Dr. Loyd, I'm going to ask Ms. Ray Bond to say a few words. It wouldn't be without her support. She is the CEO of the Chattanooga-Hamilton Medical Society and the force behind LifeBridge support. So Ray.
Thank you. It's really heartening to see so many folks on the call this morning. The Medical Society is throughout its history had two goals. One is to simply advocate on behalf of physicians to make Tennessee the best possible place to practice medicine. And our second goal has been to improve community health. Over the last few years, we've expanded that second mission to really have a very intentional focus on the health and well-being of physicians. And that's why we created the LifeBridge program, which includes a counseling resource and programming such as some of the things you're going to see this month. I want to acknowledge Dr. Carlos Baliera, who's on our call. He's a CHI Memorial Doctor, a critical care pulmonologist, and he's the president this year of the Medical Society. And he and the entire Medical Society and Foundation boards are completely supportive and have been driving forces in helping us create and support the LifeBridge program. So I just want to acknowledge his presence this morning. And Dr. James Haynes is our immediate past president. And so you're all very well of his incredible leadership abilities. And he's been a real beacon of light for us in this community and in the medical community throughout the COVID pandemic. So I'm very excited that Dr. Loyd can be with us today. So I'm going to let Dr. Panda move on to the introduction, but please know that the Medical Society and LifeBridge are here to support you at every stage of your medical career and even in those moments of crisis. Thanks.
Thank you, Ray. Again, thank you all for being here. You care, and that's why you're here today. Thank you. With that, I'd like to introduce our speaker, which we are really eager to hear from. Actually, Dr. Loyd, we really want to thank you for accepting our invitation again. Your words are so inspirational, and we thought it would be just perfect to have you as our inaugural speaker. Dr. Loyd currently serves as the Chief Medical Officer of Cedar Recovery, which is an addiction treatment company headquartered in Mount Juliet, Tennessee, and it serves the patients across Middle Tennessee. While doing his work at Cedar, he is also currently a member of the Tennessee Board of Medical Examiners, as well as serving as a federal expert witness. He's a nationally recognized thought leader and clinician. He has decades of experience in internal medicine, mental health, and substance abuse services. He also served as the medical director and assistant commissioner for substance abuse services with the Tennessee Department of Mental Health and Substance Abuse Services. His own personal story is so powerful, and his ability to turn that into something that pays forward and impacts the lives in a better way for so many is what gives us and continues to give us inspiration and hope. And no better person to share that than Dr. Loyd himself. Dr. Loyd, welcome.
Thanks, Dr. Panda. Dr. Panda, can you hear me?
We can hear you, sir, and you have to share your slides.
Am I not sharing them right now?
No.
I don't know what I did wrong because...
if you don't mind, just if you see on the bottom of the screen, you have a green thing that says share screen.
Yeah, I can't get back into any of that. When you took it, that was my fear when you took that thing over. Okay.
Okay. I'll tell you, could you send it to us?
I can. Hold on. I think I can get back to my meeting. I did.
Okay.
Okay, hang on. It won't let me share my screen. Oh, there it is. Okay. Now it'll let me share it. All right, can you see it?
Perfect, yes.
Oh gosh, yes, my heart rate that went down went back up again. And so I apologize for that.
Resiliency in action.
I want to start off this morning with just a couple of things before I get started. There are several people on the call that I want to thank for being here. Doctors Becca Martin and Karen Rogers are colleagues and friends of mine. So, and they're from the Chattanooga area. So Becca and Karen, thank you for being here. I have two friends from the medical board, Dr. Melanie Blake and Mr. Archie Ellis, community member of our medical board from Knoxville. I have been friends and colleagues of theirs now for over 2 years. And I want both of them to know that I love them and I always appreciate their support. And thank you for being here today. And the last person I want to acknowledge, I'm going to acknowledge within the story. Dr. Haynes, thank you for sharing the poem. As I sat here and listened to that, it took me back to my own time. It took me back to where I was at a place in my life. And back in 2000, I started experimenting with hydrocodone on my way home from work one day as the chief resident in my internal medicine residency training program. Within 3 years, I was using 500 milligrams of oxycodone and about 6 to 8 milligrams of Xanax a day, practicing in a hospital setting, teaching medical students and residents and taking care of patients. And as I listened to the poem, I lived that, and I lived it again a little later in my life that I'm going to tell you about momentarily. And I spiraled down, just like Dr. Barker was talking about. And what Dr. Barker was talking about as we spiral down, how we get back up is actually community and relationship. It's making ourselves vulnerable to other people who care about us so that we can share our hurts, our fears, our wants, our needs, and then have those met. And I'm going to be completely honest with you. We do that horribly in our profession. It is the thing that I think that separates us from our colleagues and prevents us from having meaningful relationships. So everything that's been said up to this point is an absolute perfect fit into what I want to talk about today, because my addiction to benzodiazepines and opioid pain medication saved my life. The thing that I took away from that more than anything was the ability to make myself vulnerable and the ability to ask for help. I got out of treatment. I did very, very well. The president of my university, Dr. Paul Stanton, the dean of my medical school at East Tennessee State, Dr. Ron Franks, they believed in me. They gave me a chance, and my career did nothing but go up. I became residency program director of our internal medicine residency program. I became chief of staff for education at Mountain Home VA Medical Center. I became the chief of medicine for the VA. I became the chief of staff for a limited period of time at the VA, and then I moved into my role with the state. So my career was going nothing but up, but I still had these underlying things that I hadn't addressed. I started suffering symptoms of PTSD when I was working for the state of Tennessee, and I started to spiral down as I started to have nightmares and flashbacks, things that I'd never happened. And keep in mind, guys, my substance use was far in the past. I've been in continuous sobriety since July 8th, 2004. And I got to the point that I was spiraling down, and I had the inability at that time to reach out for help. I was at a bad place in my life, and I wound up on the edge of my bed in an apartment in Mount Juliet. And I decided that I couldn't go any further. I was at the stanza of the poem that Dr. Haynes wrote, and I couldn't go any further. And I had a loaded gun in my lap. And I actually brought the gun up to my head with the hammer back. And I couldn't believe that that's how this was going to end. And in that moment, I remembered, ask for help. And it just rang in my head. I'd heard it so many times in my recovery groups through the years, and men and women that had been so important to me in my life. Ask for help, ask for help, ask for help. And at that point, I didn't have any idea what was going to happen. But I picked up the phone, and it was early in the morning, and I called Mike Barron. Mike answered the phone. And I told Mike what was going on, and I didn't tell him that I had a loaded sidearm in my lap, but I know Mike knows that now. And Mike helped me that day. He turned me on to a place out in Dixon that I'm going to talk about in a little while called On-Site. And I got help with the physical and the sexual abuse that I suffered as a child. And it changed my life. And Mike, I never tell you enough, but I love you. I know you know that. And I want to thank you for that moment, because it was early I think it was a Monday morning. You didn't have to answer the phone, and you did. And the direction you gave me in that moment saved my life. And I am so thankful for you. And that's how I want to get into this talk. Because when Dr. Panda, and I'm sorry, guys, I haven't done one like this. I've done a lot of talks on addiction, and I've melded my story in, but I haven't done one like this before. So when Dr. Panda called me and told me what she would like, immediately I thought of the title right off the bat. Eating, drinking, and bowel movements are signs of weakness, which is probably a little bit unusual title for a talk at an early morning grand round setting. I was a third-year medical student at my medical school in East Tennessee State. It was the first day of my OBGYN rotation, and my OBGYN rotation was my very first clinical rotation. And I was on call that night. Now, this is a different time period. This is in the 90s, and things weren't structured like they are now. But this is in the 90s, and we delivered, I think we delivered 5 babies that night. I was up all night long. I had no idea. I had never presented a case to an attending physician. I had never been to a morning report. I had absolutely no clue what I was doing. Yet in my mind, I thought I should somehow know all of that, because 2 of the babies I was responsible for that night, and I was going to have to present them. And I was an absolute basket case. I hadn't slept all night long. I had a chief resident who basically stayed in his room and was of no help to me at all. And I'm still a little salty about that to this day. He didn't help me with my presentations. And as we were walking in, I was really nervous. I was tired. I had gotten to the hospital at 7 o'clock or 6 o'clock the previous morning. So this was 7 a.m. So I had been awake for 25 hours, at least 25 hours. And I pulled the attending aside. I didn't know him. And I told him, what I was feeling. And he looked at me and laughed, and he said, eating, drinking, and bowel movements are signs of weakness. I hope that I never respond to a medical student, house staff, or a colleague with those words, because I lived the next 3, 4, 5, 6 years of my life with those words ringing in my head. I wasn't going to allow anybody to see that I didn't know, that I was scared. I wasn't going to allow anybody to see my vulnerability. And that is part of the story that set me on my path, because I'm going to frame my talk today around my own story. And part of that is substance use, but I want you to understand how substance use fits in here, as well as mental illness, because I think a lot of what we do as providers, as doctors, is that we don't have the ability to show our feelings. We don't have that community or that network to engage in. And so we travel down the spiral staircase, and some people wound up where I wound up, and some people wound up where Dr. Capote wound up. I did not know Dr. Capote. My friend Melanie Blake sent me his obituary, and I read it, and I related so much to it, and I can only imagine what it was like for him. And I am so sorry that he didn't feel like he had that community that I have, because guys, I think that's the difference. I think the answer to what we're talking about here, and I'm going to talk about quite a few things, but the real answer is community and relationship. And to the attending physicians that we have on this call, the majority of what we learn as medical students and residents are not in the written curriculum. They're in the unwritten curriculum. They're in our words, in our actions, and how we treat our patients on a day-to-day basis. They're in our words and our actions on how we treat nursing staff and the staff that support us to do the jobs that we are all trained to do in our hospitals and offices. And most importantly to me, our house staff, our residents and young medical students who are really, really bright. I don't know about the attendings on the line now, but when I'm with them, and I was with them yesterday at Vanderbilt, they're so much smarter than me. The only advantage I have is I get to direct the conversation, but I have so much to share with them about taking care of themselves. And this is how I always lead. In the doctor-patient relationship, if we're sitting in a room, which one of the two, the doctor or the patient, is the most important? And I get the same answer from medical students and residents every single time. The patient is the most important. And I'm going to respectfully disagree. The most important person in a doctor-patient relationship is the doctor. Okay? Because if I'm not okay, and you're coming to me for help, I've got very little I'm going to be able to help you with. And so we're both in trouble. And I always use the analogy of getting on an airplane. And when the flight attendant is telling us about if the plane loses pressurization, the oxygen will come down. It doesn't say put it on your kid first. It says put it on you first, so that you can be aware and not become hypoxic and be able to help the person next to you. So when I think about this, and I think about physician health, physician wellness, I think about what we do, Archie and Melanie on our Tennessee Board of Medical Examiners. Part of protecting our citizens, and part of protecting the health, safety, and welfare of the citizens of the state of Tennessee is protecting the health, safety, and welfare of our doctors who are providing that care. So with that said, I want to start off with one of my favorite quotes. It's by Teddy Roosevelt, and it's a little bit long, but bear with me. Teddy says, "It's not the critic who counts, not the man who points out how the strong stumble or where the doer of deeds could have done them better. The credit belongs to the man who is actually in the arena, whose face is marred by dust and sweat and blood, who strives valiantly, who errs, who comes up short again and again, because there is no effort without error and shortcoming. But who does actually strive to do the deeds? Who knows great enthusiasms, great devotion, who spends himself in a worthy cause, who at best, in the end, knows the triumph of high achievement, and who at the worst, if he fails, at least fails while daring greatly, so that his place shall never be with those cold and timid souls who neither know victory nor defeat." And I love that quote. I'm sorry about the male context of it. I think that's all of us, a male, female, or other. And I think that when I read that quote, it inspires me to go on, because in our role of physicians, we're not going to know the answer always. We're going to do the exact right thing a lot of times, and we're going to have bad outcomes. We're going to have patients that bring lawsuits against us when we tried our level best to help them. We're going to have people curse us. We're going to have people second guess us because of care that we delivered with our best intention. And we did the best we can, and we are going to fail. My question to all of us is, what are we going to do with that failure? Are we going to turn it inward? Are we going to medicate it? Are we going to share it with others to help us deal with the realities of our profession of helping other people? And I'm going to tell you that in my experience, it's come down to the things that you have on your screen right now. Now, there's a lot of feelings out there, and we can put them all into categories. But for me, it comes down to these: glad, sad, angry, hurt, shame, fear, guilt, lonely. Only one of those look good, but each of those have gifts, and each of those have impaired states. And when we grow up in environments, we're not allowed to express our feelings in meaningful relationship, we tend to live in the impaired state. And I think that we as healthcare providers and as doctors live in that impaired state. And sadly, I think our training has a lot to do with that. So I'm going to cover 3 of these specifically a little bit later on, but I can tell you that unless we are in touch with our feelings, and the first person that we are in relationship with is ourselves, we are not going to have the ability to open ourselves up and to be vulnerable. And if we cannot open ourselves up and allow ourselves to be vulnerable, we stand little to no chance of being in meaningful relationship with another human being. And I'm so grateful for the Tennessee Medical Foundation and Dr. Barron's predecessor, Roland Gray, and Dr. Barron for the things that they have given me, because these are the things that I have learned, and these are the things that I practice in my life that allow me to live my life as I get to now. Because I'm going to tell you this, guys, regardless of the story that I shared with you at the beginning, I love being a doctor. I love helping people with substance use disorder. I get excited about it every single day. If you come in my hospital and you see me walking around, most of the doctors, unfortunately, in my hospital have sad and dreary looks on their faces another day. And I wear this same one right here every day, even in times of hardness, because I know that I have people that I can reach out to. And I think our colleagues need to know that as well, because I think a lot of them are suffering. I think a lot of them medicate either with substances or medications to treat anxiety and depressive disorder, and nobody around them knows the things that are going on in their lives. And I think that's evident when you look at our lifespan, when you look at how well we take care of ourselves, and sometimes when you look at our divorce rates and the kind of fathers and mothers we are in our own family. So when I talk about substance use disorder, I'm going to cover this really quickly because I want to get to what I call the second 7. But I covered in the terms of the biopsychosocial model. And I really don't like psychobabble. It makes me vomit a little bit in the back of my throat. And I'm sorry if there are any psychiatrists on our call. I don't mean anything by that. I am not a psychiatrist at all, nor am I a psychologist. But when I'm looking at the biopsychosocial model, I understand it in terms of a slot machine. And so my risk, or someone's risk of a substance use disorder, comes down to this. The first 7 is the biology part, inherited. About 60% of the people with an SUD have a family history of substance use disorder or mental health disorders. And so when I see that family history, I know that the person in front of me is at slightly elevated risk to develop themselves on down the line. The second 7 is the psycho part of the biopsychosocial model. And that really comes down to what kind of household were we raised in? Because I don't want any of us to be under the impression that we come out of normal households. They don't exist. But some of us come out of places that maybe are a little bit worse than others. Some of us come out of places with physical abuse, sexual abuse, or emotional abuse. And I'm going to talk about that. When I talk about second 7 stuff, those are the things that I'm going to focus on. So the young Dr. Steve Loyd, back as a chief resident, had a family history of substance use disorder. He have 18 first cousins on my line in our family tree, and 4 of us have passed away from overdoses of drugs or alcohol before age 40. So my family history is there. That's the bio part. The psycho part, growing up, I was abused. My mother, who is a great grandmother and has grown tremendously since those years, but she was physically abusive with belts and sticks and things that, you know, are just not meant for disciplinary measures. And she also had untreated bipolar disorder. So I was living with somebody who had untreated mental health disorder. And then last but not least, I was sexually abused by an uncle. Molestation at first that progressed to worse things later on. So now here I am sitting with this family history and this baggage of childhood trauma that I'm carrying around with me. And that third 7 is just the social opportunity. And with the widespread use of prescription opioids and drugs like Xanax and Klonopin and Valium, and me as a young medical provider having access to those, I found the thing that gave me relief from this traumatic pain that I had been carrying around since childhood. And people make the mistake here, go, well, you've made it as far as you made it. I was the first person in my family to ever graduate from college. I was for sure the first one to go and graduate from medical school and residency. And I kept putting these things on my wall. I was AOA in medical school, and I put that on my wall. And I put my diplomas on my wall, and I put my residency certificates and my chief resident certificates. And I was hoping at some point that I would finally find that thing inside of me that filled me up, that made me feel comfortable in my own skin. And guys, I never found it. I never found it. I kept chasing it and I kept chasing it. The house I'm talking to you from today, as a little boy, I could never dream of living in this house. Matter of fact, this neighborhood that I live in, as a little boy, my family used to drive us through this neighborhoods at Christmas time so we could see the rich people's Christmas lights. And so I had all of that, and it didn't matter because I still had this thing inside of me that I didn't feel whole, that I didn't feel comfortable in my own skin, that I didn't feel like I was enough. And I discovered substances. And when I discovered substances, it took that stuff away. But here's why I want to talk about substances in the context of this, because I got treatment for that substance. I got help with that. And I was very, very successful thanks to a lot of really great people. But I had never truly addressed the underlying drivers in that second 7, my physical, sexual, and emotional abuse, my feelings of being less than. I'd never done that. And I wound up on the edge of the bed with that loaded gun in my hand and nearly took my own life. And I want you to understand how that is possible. So if we look at the brain, and I'm not going to go in depth in this, and I'm hoping you all can see my cursor, but there's 2 areas I want to focus on just quickly. One is buried deep within the area of the brain I'm circling right now. It's our ancient limbic system. It's the reward system of our brain. It's where we derive pleasure from food, water, sex, watching our children play sports or be in the band or just being around family. And the other area of our brain I want to talk about is everything in front of the sulcus here, the frontal lobe of our brain. The frontal lobe of our brain is responsible for insight, judgment, and empathy. And what happens when people are covering their feelings, those 8 feelings that I listed? What happens when you're living in that impaired state and you can't deal with the realities of your life? And the poem that Dr. Haynes shared with us, I loved hearing that, although it made me quake inside. I loved hearing that because that's somebody who's struggling with the ability to handle their feelings. They don't have an outlet and they start questioning themselves. Am I enough? Am I enough? And what that young man is dealing with is shame. Guys, there's a difference between shame and guilt. Okay. Guilt is I messed up. Yeah. Well, welcome to the real world. So's everybody. Shame is there's something wrong with me. And as I listened to that poem, I had shame running around in my head because I've been right there. Am I enough? Right? And then the frontal lobe of my brain gives me insight, judgment, and empathy. And whenever I am under the influence of any substance or anything that I'm using to cover my feelings and avoiding dealing with the reality of my world, okay, I lose access to the frontal lobe of my brain. It's like I've had a lobotomy. And so I'm totally driven by these things that give me relief from the either physical or emotional pain that I'm carrying around with me. Okay. And I think if we understand that, we can see how people get to the point that they get to. We can see how young Dr. Capote got to the point he did, because everything I read, when I read his obituary, I read the obituary, but I went down and I read all the comments that his friends posted. And this is a guy I wanted to know. This is a guy that was more than enough. And this was a guy that didn't know that. He didn't know that. This is a preventable death. I know because I was Walter a few years ago, and I'm sitting here talking to you today. This is preventable. If we establish community and relationship, and we start to peel away some of the stigma that's associated with this, and we allow ourselves to be vulnerable with our colleagues, then guys, we'll start moving the needle and we'll start going forward. We'll start taking better care of ourselves. And I submit to you that we will provide better care to our patients. The thing we need to remember whenever we have substance use disorder, we have things that we're using to cover our feelings, is that it takes a while for our brains to recover. I love this slide. This is from one of my medical heroes, Nora Vocal, back in the 90s. And this top row of brains are PET scans of normal brains, and you can see the uptake throughout the brains. Look at this second row of brains. So brains have been off of substances and guys, the reason I'm saying this is this happens in all addictive processes, not just substances. So if you're covering your feelings with sex, with internet pornography, with gambling, with religion, or whatever it is, these same pathways are affected. And we lose access. Look at somebody who has been drug-free for 10 days. Look at what they have in uptake of the frontal lobe of their brain. But they're still driven by that pleasure center. And we look at doctors and the work that Dr. Barron does. When we start to get our doctors help, they're gone away for at least 3 months, and they always fuss, but it's such the biggest gift, because at the end of those 3 months, they're starting to have the return of that frontal lobe function. And more importantly, they're established in this community where they can have meaningful relationship and get together every now and then and talk about their day and what went wrong and what they're feeling. And it is such a gift to have that outlet and to be able to share that. And taking it to the next step, being able to have people to help you with the underlying traumas that have driven you your entire life. And I want you to understand this, because there is hope. This is not, as Dr. Barker was saying, in the spiral staircase coming down, you get to go back up. And when you get up at the top, there is sunlight. There is the world. So there is hope. And I am here in front of you today as living proof of that. And I am not the Lone Ranger. Second 7 stuff all goes back to this guy, another one of my medical heroes, Dr. Vincent Felitti, a weight loss doctor in California, who's the lead author of the ACEs study. And if you're not familiar with ACEs, I would start out by Googling it. That's good enough. That's a good enough start. But what Dr. Felitti's ACEs study shows that when we get to an ACEs score, and there's 10 categories of 4 or above adverse childhood experiences, our risk for substance use disorder, our risk for mental health disorders such as anxiety, depression, post-traumatic stress disorder, our risk for diabetes, hypertension, all the things we think of as being real diseases, our risk for all of those things goes dramatically up at an ACEs score of 4. So we actually have a way to screen for this and step in and intervene. And so my physician colleagues on this call, I'd encourage you, have a look at that. Be careful taking it on your own. But we are very good at physicians at minimizing things. Oh, I pulled myself up by my bootstraps and I got through that. Look where I am in my life. Look at what neighborhood I live in. Look at what I put on the wall. I put all that stuff behind me. Yeah, if you open up my medicine cabinet, I'm on 2 SSRIs and a benzo. And I'm not saying that there aren't roles for medication, but I am saying there's a problem there. And I am saying that the real help in this world involves getting help with those things and being established in a community where we can have meaningful relationship. So I'm going to go back to my feelings, and these are my big 3. And so when you look at those feelings, you think, golly, all those sound bad. I don't want any part of any of them. But you have to remember that feelings are there for a reason, and there are gifts associated with those feelings. And so angry, guys, I'm the angriest man around. I promise you I am. I am an angry dude. but I am no longer anger in the impaired state. When we turn our anger in and we say, oh, that didn't bother me, we get our feelings hurt. A patient says bad things about us or brings a lawsuit against us for something unjust. We're not getting recognition that we've worked really hard for, and we turn that anger inward. That leads to depression. That is the impaired state. Healthy anger, anger expressed, anger voiced, anger written down and shared with somebody else leads to the gift of passion. And I am a passionate guy. I'm a passionate guy on this call. I love living my life like this, but there are hurts that come along with that. Because when you're passionate like I am, you get darts thrown at you, and those darts hurt. And I don't have hurt on here, but hurt is one of those feelings. And I got to be really careful with that hurt, that I don't respond to it in the wrong way. Okay, because healthy hurt leads to forgiveness. And the more that I can be about forgiveness and meeting people where they are, the more effective I am at providing care to my patients with awful substance use disorders. The second one is fear. Guys, we're all scared. That young medical student walking in the morning report with those babies to deliver a presentation on that he had no idea what he was doing. And the weird thing about that situation is I had never done it before. Nobody had sit down and told me how to present the pertinent positives and pertinent negatives to my attending physician. Yet when I'm presenting and I'm trying to cover everything that I think is pertinent, keep in mind it's the first day of the rotation. People are interrupting me rudely and going, that's not important, move on. I just went further down in my shell. And I made up my mind that I was going to be the best presenter I could, and I wasn't going to let those son of a bitches ever do that to me again. And they didn't. And they didn't. But that's not what we need to recognize. We need to recognize the fear and the vulnerability in our trainees and being able to walk them through that. Because I promise you it's there, and you go back to your own training. And I promise you it was there for you as well. So fear is a good thing. Me walking into that situation was a good thing, because handled in the right thing, healthy fear leads to wisdom. Healthy fear leads to wisdom I gained from that experience that day, so that I'm able to do that situation better. And the next time I'm taking care of those patients during the night, I know the things that are pertinent. I know the things that I can put on the back burner. I know the things that I can manage my time a little better with. But I didn't go that route. The way I was positioned that day, eating, drinking, and bowel movements are signs of weakness. I went the other way. My anxiety went through the roof. I'm sitting there. Am I good enough? The poem. Can I do this? Do I have the tools to do it? I think I do, but everything I'm seeing around me is telling me I don't. What's wrong here? It's exactly how I felt. And guys, this is what we don't understand about rage. Rage is not fear. Rage is anxiety and fear that we hadn't dealt with. Okay, if you see a doctor throwing a scalpel, it ain't got anything to do with him or her being mad. It has everything to do with him or her not dealing with an underlying fear. We have to get to the root of that fear and help them with it, help them express it. We may not be able to do anything about it, but here's what I learned about these things we keep inside of us. They're obligate anaerobes. And you all know this. Obligate anaerobes can't live in the presence of oxygen. So when I get these things inside of me out and they hit air, they lose their power. When I talked to Mike Barron on the edge of my bed that day with a loaded gun in my lap, and those things hit air, they lost a little bit of their power. I gained a little bit of insight, and I gained just a tiny bit of hope. And hell, guys, that's all I needed. And Mike provided it for me in that moment. And then last but not least is shame. Shame can be a really good thing. Healthy shame leads to humility, right? Sometimes I get to thinking it's all about me, and I'll stick my chest out and my ego gets too big. And then I can be reminded of some of the things I've had to walk through. And that's a good thing. It's humility. Toxic shame is what I felt in that moment. It's what it would be my guess of what young Dr. Capote was feeling, and the young man who wrote the poem that Dr. Haynes shared with us. And that is not a healthy thing. The good news is, with all of these things, there is hope. I would encourage you, the only book I would recommend, I'm a huge fan. If you don't have the attention span to last an entire book, I would recommend her TED Talk. It's from TEDx Houston several years ago. It's one of the 5 most viewed TED Talks. And another one of my medical heroes, Renee Brown, who is a vulnerability expert. But the thing I want you to take away from Renee, because I get this from students and residents and colleagues all the time. Oh, I'm a perfectionist. And we hide behind that. We hide behind our perfectionism, because perfectionism is an attempt to cover our vulnerability. And it's going to fail 100% of the time. The surgeons on this line, you've all made mistakes. You've had bad outcomes. You are not perfect, no matter what you think. You haven't been perfect in your profession. You haven't been perfect as fathers or mothers, and you haven't been perfect in relationships. So we need to abolish the thought of perfectionism, because perfectionism is an attempt to hide our vulnerability. And guys, I didn't start getting better until I allowed myself to open up and allowed myself to be vulnerable, to be seen as who I really am, and to be accepted. Now, you don't do that with just anybody, because there are people out there to hurt you. And there you need help with discernment. And that's another talk altogether. But I think that this is the real key, that whenever we can establish that in ourselves and in our colleagues, we will really start to move forward. And I think that starts with things like you guys are doing right now with the efforts of Ray and Dr. Panda. So if we look at our training environment, my friend Roland Gray, who passed away, Roland was Dr. Barron's predecessor with the Tennessee Medical Foundation. And I had many talks with Roland about this in my time with him. And he told me one day, Steve, nobody goes through residency without being permanently scarred. And I think we should be embarrassed by this. I think we should be embarrassed at the way we handle ourselves in M&M conference, because M&M conference is a unique opportunity to sit back and look at a case and think about where we could have done better. But we don't do that. We take somebody up in front of an audience and we pack the room out and we poke holes in them and we second guess them and we don't give constructive criticism. It's why nobody wants to present at M&M conference. And here's the dirty truth. It's why you make the interns do it, because you can't make anybody else do it. And guys, we have got to get away from education in that environment. M&M can be a beautiful thing. We learn from things that we could have done differently. It is so good and so fruitful. But whenever you're sitting there trying to defend yourself and you're turning these things in and on yourself, it hurts our overall well-being. And I'm going to promise you that it results in worse patient care. And in that same vein, I want to talk about this idea of pimping. Pimping is this time-honored tradition of the omniscient attending walking around the hospital with the white coat while the minions wait for wisdom to be dispersed. Now, that can be a good learning environment, but when it turns into a game of guess what I'm thinking and beating somebody down in the presence of their peers, that's not okay, and we need to abolish that. We can still engage in that Socratic method, but it doesn't have to be like that, because I'm telling you, that we're causing harm. We're causing harm to our trainees in the way that they take care of patients and the way that they're living their lives. And more importantly, in their ability to say, hey, I'm struggling and I need help. You can't let anybody see that I don't know. The young third-year medical student walking in, and I hadn't slept all night, but I was freshly shaven. My teeth were brushed. I had on a tie and a sport jacket and the only pair of khakis I owned. I couldn't let them see that I didn't know. I couldn't ask for help. Who am I going to ask? The guy I asked for help told me eating, drinking, and bowel movements were signs of weakness. And guys, we have to change that environment. It is inherent upon us to change this. Can't ask for help because I don't want anybody to know I'm struggling. It could hurt my evaluation. If I go in there and I get somebody to help me, hey, could you sit with me and help me through this and help me, at least get my feet on the ground? And then I get my evaluation back and I'm evaluated a little lower because I didn't somehow inherently know this. The ACGME limits our work hours to 80 hours per week. Guys, that's 2 full-time jobs. I don't know what else to say about that. I've heard attendings say, well, that's really going to hurt us. We don't have enough time for training. Yes, we do. And if we don't, then extend the training period, right? And training is not about learning how to pass the in-service exam or board exams. Those things are all positive. Training is about how to become a present and an all-encompassing provider of care to people in need. And there's more to it than taking the test. There's more to it than a board exam. And I think that we need to model that in our unspoken curriculum. And I think we need to take a real look at how we address burnout and stress in our house staff, our medical students, and our colleagues. And then I've already talked about toxic shame and preventing. So how can we help? This is my takeaway from here. When do you know if somebody's struggling? This is my litmus test. That's just not the same person I used to know. What in the world is going on? Right? When I have that come across my mind, that's my test. And here's the weird thing. I now have enough confidence inside of me and in my own comfort, thanks to the help of people like Mike Barron and my friends now, Melanie and Archie and the people in my inner circle, to step into a situation that I'm uncomfortable in and go, hey, tell me what's going on. what's happening with you? You're not the same. There's something happening here that I want to better understand because I feel like you're struggling. All right. And to me, that's the approach that I use. We're all doctors, so we like acronyms. AMA has put this out, and it's very good around physician health. Observe, watching our colleagues and behaviors for pattern. We state our observation. Hey, here's what I see. And I mean it in a loving and meaningful way. Not, hey, I'm going to report you here or I'm going to get you disciplined here. None of that. And one of the things that I do is I share a little bit of my story so that we can start to connect, because there's going to be people on this call today that have listened to my talk and we're going to have connected. You're going to think, I did that too. I feel like that. I felt like that. Or I'm struggling with this in myself right now, and I don't know who to tell, who to call, who to help. If there's anybody on this call, if you don't know anybody else, you can call me. I'll help you. But there are others, and I'm going to get to those momentarily. We want to clarify our roles. Why I'm concerned. I'm not coming to you as the chief of staff. I'm not coming to you as the chief of medicine. I'm coming to you as a colleague who's been there myself. I'm coming to you as a colleague who is a better dad and a better husband because of things that people helped me with in the past. That's why I'm here in front of you today. And this is how I approach these situations in my role on the medical board as well. I want to ask why. Help me understand what's going on. And then lastly, respond. I know you got a lot going on, and I have been there myself. If you can't talk to me, is there anyone you would be willing to talk to? And I think that's a reasonable approach without overthinking it. And I can tell you that always, if you don't feel comfortable at all and you're just concerned, you can call that group at the bottom, the Tennessee Medical Foundation. Your last speaker in this series is going to be Dr. Mike Barron, who is the medical officer, the chief medical officer for, or the medical director for the Tennessee Medical Foundation. And I can tell you as a medical board, we respect the work done by the TMF, and we get the privilege of watching our colleagues rehabilitate their lives and put them back together. And it's really due in large part to the work done by the TMF. What I would like to see is the TMF present in all healthcare facilities around our state, and that we have groups that can get together and talk about our days in an open environment that's not threatening, where we can admit our fears and we can grow from them. That's the ultimate dream, lifelong, instead of when we get people either in front of us with a board or when they've presented in an acute situation. And I don't have any financial interest in anything around this, but I can tell you the work done at on-site around trauma, around physical, sexual, emotional abuse is unmatched anywhere that I've ever seen. I'm going to close with one of my favorite, well, actually my favorite show right now. I recommended one book. I've got one quote from Teddy Roosevelt. So we'll close with a quote from the great Ted Lasso. This is it's not Netflix. I think it's Apple TV. It's only in its second season. I highly recommend it because there's so much medicine in Ted Lasso, guys. I promise you. Ted said, "Be curious, not judgmental." I want to be curious. I don't want to bring my own stuff. I don't want to bring my own judgment. If I can do that, my oxygen mask is on, and I got a pretty good chance of being able to help the person that's right in front of me. Why does it matter? This is the most important slide I have. That's my family. In the background is Florence, Italy. And you can see it back here. Somewhere as a little boy, I never dreamed I would get to go. I got to take my family there before the pandemic. That's my son, Heath, my now daughter-in-law, Laura. That's my wife, Karen. I still had a little peach fuzz back then. That's me. This is my daughter, Haley, my son-in-law, Sterling. Because I had people that allowed me to heal, I got to be in this picture. A few years ago, my daughter, Haley, got married to this thing right here. I was standing at the back, had Haley on my arm, and I was dying. I mean, I did not want to do it. And that's my little girl. And I was struggling. And Haley laid her head over on my shoulder. And she said, "Daddy, you're the first man I ever loved. Thank you for everything that you ever did for me." And guys, my day got better really, really quick. My son in March during the lockdown came into and one of the good things about the lockdown is it reinvented the family dinner. And my son walked in and he was getting married in October. And he sat down at the table and he said, "Hey, Pops," he said, "would you be the best man at my wedding?" Guys, this is what's important. This is what's important. I'm a better doctor. More importantly, I'm a better husband. I'm a better father. And I think if we keep those things in mind, that we can do this. We're not people that aren't bright, but we're going to have to break down some pretty hard barriers. But I think it's doable. With that said, thank you for letting me share my story in the last 45 minutes. Thank you. Well, I hope you all are still there.
Thank you. Thank you, Dr. Loyd. I think your story has touched a thread of our stories, I'm sure, for each and every one of us in the audience. Thank you for your own vulnerability and the courage. And thank you for really highlighting things and the life that we live, but also what is really important. With that, I'd really like to see if there are any questions or comments from the audience.
This is Dr. Saunders. I just wanted to say thank you to Dr. Loyd. That was extremely moving and forthcoming, and I'm sure that it touched more than one person in this meeting today.
Thank you, Dr. Saunders. I didn't see your name in the list, but Dr. Renee Saunders is our medical liaison to the board and does great work in helping our physicians every day. And thank you, Renee. And I love you and I love the work that you do.
Dr. Loyd, this is Upasana. I don't know if you remember me, but you were my program director when I was at ETSU. It was very good to see you, and thank you so much for sharing your story and your guidance.
I can't see you. Can you turn your camera on?
I'm actually driving.
Okay. Oh, no problem. What's your last name?
Upasana Bardhan.
Oh, I know. Yes, I know exactly who you are. Thank you. Thank you. I didn't recognize the name in the box, but thank you. Thank you, Upasana.
Yeah.
This is Dr. Keats. Your talk was extraordinarily moving. I'm a pediatric hematologist oncologist. My question to you is, how do you actually provide as a mentor or as an attending the right sounding board for people to actually be able to express themselves, not feel that they're being punished for actually being vulnerable? How do we become better reflections of what you just discussed?
I think, and thank you for the question. There's limits to this around environments that we're in, but I think my guess is, as a pediatric oncologist, there have been times in cases and patients that you're taking care of where you're stumped, or you're scared, or maybe even you made a decision that you wish you had picked another route. And I think about, after recovery and after I started living like I live now, when those things happened in the course of our day, in my rounds and in settings, in educational conferences, I was honest about that. Was honest about, hey, I don't know what's going on here and I'm frustrated. And what I tried to do was model that behavior for my students and residents. I wanted them to see that I don't have it all up here. I'm not opposed to looking something up on my phone. I'm not opposed to saying, this is out of my area, or I haven't seen this in a while. I'm gonna reach out and ask for help. And and there's one thing to write a consult in a chart. There's another thing to pick up the phone and call my buddy who is an infectious disease guy and go, hey, I've never heard of COVID-19. What the hell is this? And I'll always let them see that. Always let the house staff and residents see me in really, really difficult situations where I had patients that were hard to love, because they needed to see that. They needed to see what my reaction was to it. And then there were times I walked out of the room and said, those things that he or she just said to me, that hurt me. And I really felt like I did the best I could under the circumstances. And if I'm completely honest right now, I'm pissed. And I let him see that. I let him see the real me. And, when I was thinking about doing this talk today, I got up. I always get up early, but I'm actually in the Eastern time zones, and I came from Nashville, so it's actually even earlier. But I got up, and as I was in my quiet time this morning, I wanted to do my best today to present my authentic self to you all as close as I could. And hopefully I did that. I try to do those same things with my residency and house staff and medical students. I was at Vanderbilt all day yesterday, and I had their medical students, and I talked about this, and I'm looking at these young folks who are going to take care of us, by the way. And they were born in like 1997. And I looked at them, and I want them to know that it's okay, that you have done this thing your entire life. You got to this point in your life, but it's still okay to be scared. It's still okay to not know what you're doing. I want you to be able to ask for help, and I want you to engage in community and relationship. And so I hope I answered your question, but that's what I try to do and model for my residents. And maybe upon my previous resident could tell you if I was successful.
Oh, Dr. Loyd, you were definitely successful. You were an awesome program director. I had one question, like when we are practicing medicine, interacting with a lot of people, it is definitely very important to choose our words wisely and, think about what effect it can have on the young minds of residents and medical students. But in an event where you basically witness emotional abuse or any bad behavior that can make someone feel less than they are, how do you deal with those situations?
Well, Pasna, I think the title of my talk rings volumes. That happened in 1997. It's 2021, so 24 years ago. And when I typed that out on my slide, I had a reaction to it. And so I think we do need to be careful with that. And I think that, even as an attending and for our pediatric oncologist, I want to tell you this brief story. I make mistakes in my interactions with patients. And so we had a patient one time that came in and went into cardiac arrest. And I mean, right off the bat, we were seeing them in the ED, admitting them for congestive failure, boom, cardiac arrest. Went into VFib, and it was one of those situations. I had the house staff. We shocked them back. It was a great outcome. They wound up needing an ICD. A pacer was up in the room with them the next day. The family was all around, and still rolling off the adrenaline. I had the house staff with me, and the patient is just so thankful, and what a good feeling in the room. And he said, "Doc, what's the worst thing that could happen here?" And I flippantly said, "Well, you could drop dead and die." Now, what a horrible thing to say, right? And it was totally off the cuff, totally inappropriate, totally not anywhere like that. It was just my knee jerk. I was still riding the high of the outcome, and a minute as a joke, that's not the time to joke. And so when we got back at the end of rounds, I said something to the house staff that day. I said, I want to go back and look at my response there because I've thought about that. And so we actually doubled back that day and went back to the patient's room and got his family back in there. And I told them about it. And I told them about my flippant response, and I apologized to them. I modeled behavior that I want all of us to have. And I hated doing that. I felt terrible inside of having to do that, but it was absolutely the right thing to do. So I think whenever we see it, that sometimes it needs to be in a private setting, but that we address it, Vipassana. And I don't think that there's any other way around it. And none of us are going to be perfect. We are still going to say things. Vipassana, never not Vipassana. Vipassana, I remember you very well. Vipassana is kind, compassionate, empathetic. I mean, she was a great resident, but I had residents that there were times that I said things to them. I didn't say, eating, sleeping, and bowel movements are signs of weakness, but I said things that I could have done a whole lot better job with, that I had to double back and talk to them about it. and talk to them about how I could handle it better, and to please speak up and feel free to confront me if anything like that happened again.
And Dr. Loyd.
Yes.
Hey, this is Reeves. Can you hear me okay?
Yeah.
Oh, hey, Reeves. Yes, I can. How you doing, Reeves?
Yeah, I'm doing great. What a beautiful job. Thank you so much for putting all that hard effort and passion into your speech. That needs to be heard by every doctor in Tennessee, and I wish there was some way to arrange that. But thank you so much. Here's my question. This is all about suicide awareness. And as a physician, and probably some of my colleagues here that are on this call, being aware of your patients when they may be getting near that point, and recognizing it, and you being close to that point. And I've had patients, unfortunately, have been successful, and I've had some that have been unsuccessful in suicide. And I know there's things like inability to sleep or loss of sleep that are some of the warning signs. Could you touch a little bit about that, maybe on your own personal side? What were some of the signs? Was it a gradual progression to suicide, or it was more acute, or was there some warning signs that you experienced or that we would know about to look for in our patients? Thank you.
Yes, thanks, Dr. Johnson. And I will talk about it personally, because we're going to have two speakers that come along after me. They'll be very, very in a whole lot better place to talk about those. But I will tell you this. For me, the warning signs were that I had started to disengage. Dr. Barker thankfully shared that the visit of the spiral, and I had begun to disengage. I had begun to pull away from relationships that were really important to me. I had lost my passion. I became involved in administrative wars that I just absolutely abhorred. I'd never been like that. I started to slip in my work. I started to not be timely in the things that, and so Reeves, for me, I go back to that first thing I put up, just not the same person I used to know. When I see that, it's a time for me to step in and go, I got no idea, right? Be curious, not judgmental. Hey, tell me what's going on. And I don't know if Mike would be comfortable in answering this, but I'm quite sure that Dr. Barron remembers that morning that I called him. And Mike, do you care to share just a little bit of your approach to that day?
Sure. It was approached to many phone calls I get, and I really want to emphasize that it was the act of the actual reaching out that helped more than anything that I was able to do. You were asking for help, and I think that's a huge the rate limiting step that we see with people that do go on to act on suicide, is that they don't reach out for help. All I did was answer the phone call, and I pointed you in the right direction. I made some phone calls on the other end to say, get this guy in now, and it worked out. But just the act that you reached out for help was critical, and I just cannot emphasize that enough. And I will discuss things about the personality changes that do occur with someone that gets depressed and is more prone to act with suicide. I'm always hesitant to use the words a successful suicide, because suicide is not a success. It's a failure of everyone around that individual. So the American Foundation for Suicide Prevention asks us not to use a completed suicide or a successful suicide, because it's a failure. It really is. But I'll be glad to talk more on that in 2 weeks from this morning. I'm still in my pajamas, so that's why my video is up there.
All right. Thanks, Dr. Barron, and thank you for being here this morning.
Well, if it's 8:15, I just wanted to say that, we can stay around for a little bit, but wanted to once again take this time to really thank everybody. And really, I wanted to leave with a few things, reiterate what Dr. Loyd said and what you've heard from our other speakers this morning. I think as we go out today and the rest of our time together, let's remember to see each other, but more importantly, hear each other and show each other that we care. Let's show each other that we care and they matter. And in turn, let's do that for each other. Let's build community and build relationships, because in the end, what is community? It is nothing else but a common unity around a shared covenant. And we are all here to make a difference and take care of our patients and our community. And let's do that by taking care of each other and ourselves. So thank you, Dr. Loyd, and thank you all for being here. We are in this together. We are a community, and we need each other to lean on. So thank you for being there and fueling my passion, because I couldn't do this without each of you. So thank you, and have a great and blessed day.
Thank you all.
Great job, Dr. Loyd.
Thanks, Mike.